Good morning. This is Dr. John Bennett, televising from Miami Beach, home of Neurosurgical TV. We are blessed today to have UHA's Neurosurgery Grand Rounds, and UHA is arranged for kind of a televising of Yasser Gill, Dr. Yasser Gill, and he's going to give an introduction. And we also are being televised into Chinese by Ben Zhu. He's good enough to get us hooked up with the Chinese neurosurgery community, whom UHA is trying to reach. Okay, I'll let UHA run the show. Okay, UHA, it's all yours.
Thank you, John. Dear colleagues, so I have a very short introduction because Professor Yasser Gill doesn't need any introduction. There are 50,000 neurosurgeons in the world. If you don't know the name of Yasser Gill, you are certainly not a neurosurgeon. So Professor M.K.C. Yasser Gill was born in 1925 in Turkey. With 18 years during the Second World War, he moved to Germany to study, but then moved to Basel, Switzerland, and from there continued to Zurich. So he's the greatest neurosurgeon of all the times. His lifetime work was in Zurich. After retiring in Zurich, Switzerland, he moved to Little Rock, to Al-Mefti and Ali Christ. And after finishing in Little Rock, he moved to Istanbul, where he's working with Professor Ugur Dure, joining the operations and the writing heavily. So what's special in Professor Yasser Gill? Has a strong will, extremely hardworking. No one can work so much. He's still active at the age of 95 years. And speaking about bypasses, so he did first STA MCA bypass October 30, 1967. This was a patient with Marfan syndrome and MCA occlusion. I was second year medical students, also with small medical students were following what was happening in the special world of neurosurgery. It was revolution happening. This is Professor Yasser Gill, later pictures, and here is Professor Yasser Gill with his balance microscope. You see the mouth switch and also the armrest for surgery. These are very special. Everything was designed by him to begin microneurosurgery, all the instruments and all the things. This is during my medical study times in Zurich. This is 1969, so it is a long time ago. I was working by Professor Aget in Brain Research Institute in Zurich, and there I learned to use the microscope, the first microscope, OpenV1, assisted now here by Professor Etsuro Kawana, coming from Tokyo, Japan. I studied in Zurich 1966, 1973, and then after that I went to specialize to Helsinki. After specializing in Finland and working in Kuopio, I felt I need more to study, and then I went to Zurich in 1982. There were many visitors around the world, and because it was not possible to change any words in the operation room, after 2 operations we went in a restaurant and then we discussed the beautiful operations of Professor Yasser Gill. He was #1, then there was nothing, and then some in the 3rd place that time, and we sucked all the knowledge and skills what we could see there. So later I went several times to Zurich, and finally when I became chairman in Helsinki, I invited Professor Yasser Gill to operate on, to give lectures and to operate on in Helsinki. He came 2001, and this was the first year of Helsinki life course. He continued to come 2002 and 2003. 2003, this picture was drawn by my first Chinese fellow, Wu Shen. You see Professor Yasser Gill to operate on, assisted by me and Mrs. Diane Yasser Gill. What is special in this picture? all people look Chinese, because these are Chinese eyes looking at the European people. So this was Professor Yasakil in Helsinki, and he finished 2003. Then he was followed by two of his students, Ali Christ here in the back row, left, Ugur Düre. There is Reza Dasti, my fellow, now in New York. And in the front row, Mika Niemela, the present chairman in Helsinki. In the middle, Evandro Oliveira from Brazil, and me. And this is Istanbul 2018. In the World Congress, Yasaki was giving a good lecture, and he's still active writing a book. So let's learn with the master of masters. We play now the Baibas lecture. Thank you.
Dear Professor Juha Hernesniemi, dear colleagues in Republic China, I enjoy very much to have the chance to talk to you, to tell a little from my experiences. And I like to thank Professor Hernesniemi. He asked me to participate on these lectures. It is clear that the human being have been since millenniums interested to control the bleedings by injuries, and they have been very irritated to see how young or old people may die by bleeding. So the blood vessels have been very important. Sure, the human being had also experiences by animals. They saw different type of vessels, and they saw the importance of this vessel system. I'm going to tell you now a little more about the human brain vessels. In contrast to many other organs, the human brain has a history. The history is the co-evolutionary phylogenesis, ontogenesis, and epigenesis. The human brain developed through hundreds of million years of co-evolution, numerous specific structural regions, and distinct functional circuits. Each topos in the brain is linked in the chronos in the areas and functions of the brain is directly related to a certain phylogenic, ontogenic periods of development. I don't like to enter to the old histories, but remarkable are two persons. These are later by artists created pictures. Herophilos, now 2,300 years ago, he was born just here in this area, in Asiatic part of Istanbul, Üsküdar. Then he went to the new founded city Alexandria in Egypt. The Alexander Great created many cities in Near East and even in Central Asia, and one of the most productive city and center was the Alexandria in Egypt. Herophilos, and then another Greek scientists, Erasistratos, they worked together, and they have been fortunate also to have the chance to go to the areas where they saw how the expert Egyptian doctors, not doctors, specialists, made mummification of the wealthy dead people, and they saw how the organs are built, and they had a chance to observe many anatomic informations. And then they are actually fathers of the modern anatomy. Unfortunately, we don't have any drawings, any publication in our hand. But later on, especially Paulus von Eginata is another Greek man. He gave, in the 7th century, full information about all these time periods. So we are informed about these people. And I don't like to enter more about this both founder of the anatomy, neuroanatomy. It's a big jump, almost 1700 years later. From Holland, Dutch, came the Vesalius, and interested on medicine and on anatomy. He came to Italy, in the Bologna, Padua, Pisa, Venedig, because the Pope was allowed to make the autopsies. Before, it was forbidden in many cultural centers in the world. But it started, and then he was also another pioneer. He died in a young age at 50, but he gave excellent first-time books. He was very critical towards Galen. Galen was born in the West Anatolia, in Bergama, and he was a great medicine pioneer and surgery. He was trained in Izmir, then later he went to Rome, was the doctors of the emperors, and he made a great contribution. But later on, he studied on the animals. And Vesalius made the section on human cadaver, so he found some 200 error by Galen's anatomy. And if I look to the picture of great Vesalius, I can find also some not correct drawings. There are a little mixture. Next. Since that time, it is a Renaissance time, there are at least some hundreds of great anatomists. They made a great contribution in Europe, later on also in Canada and in United States. And I enjoyed very much to found the books of Gustav Retzius, professor of anatomy in Stockholm, Sweden. He published several monographies about the human brain, then brain of the apes, and then he published also 2 large volumes about the cisternal system. It's unique, and very precise information are there. would recommend to a young colleague to find in libraries the books from Professor Retius. It's a base informations are there. Now to come to the vascular organ, which is very special, as I said at the beginning. The differentiation between arteries, capillaries, and veins, we know now together as clear knowledge. The interpretation of systemic cardiopulmonary and distinct central nervous system hemodynamics, clarification of the biology of the blood and lymph organs, elucidation of vasomotoric system, and of the enigmatic blood pressure, even nowadays, required centuries of intense investigation to achieve effective knowledge. The history of medicine presents us an impressive cooperative but also a controversial evolution of concepts and convictions related to vascular organ and unique functions. This is actually all related to other organs and all other convictions. It is good to have critics. Now, the vascular system in general and the neurovascular system in particular disclose anatomic, embryonic, histologic, genetic, physiologic, pathologic, medical, and surgical fascinating aspects. The neurovascular organ evolved into phylogenetic, ontogenic, infantile, adult, and elder age stages, stepwise. It is a heteromorphic and heterofunctional open system with a unique capacity to fluctuate and adapt according to focal and regional requirements of blood supplements. If there is a need, new vessels are created. This is unique. I like to recommend to young colleagues also the publication from Marin Padilla. He's a Portuguese originated, but he's working in New York as embryologist. I met him on a meeting, neurosurgeons, and then I enjoyed his presentation about the development of the brain vessels. I was very impressed, and I asked him, please give a chapter for us. So in the volume 3B about the AVMs, he gave, no, sorry, in 3A, he gave an excellent chapter how the meninges, the brain tissue in the vessel developed at the same time in cooperation, and then we had to find out this super architecture, the unique architecture, and I will tell you a little more later. Here we have, before I started the arteries, I'd like to show here the venous system is a much important also because it has enormous richdom. There are more veins in the brain than in other organs. And this is now well examined, but we are thankful to the publication of one Chinese colleague from Shanghai, as I remember, Yung Peng Huang. He was from Shanghai, and then he went then via Kyoto to United States in Mount Sinai. He was involved in neuroradiology and remain in neuroradiology, but he gave us the best information about the anatomy and also embryologic, the development of the venous system in the brain. Here we have him here on the nice picture. In development, interestingly, since Vesalius, we have another Dutch scientist, Friedrich Roche. He had the idea to inject into the vessel wax with color and then macerate the tissue. As you can see, he succeeded some 300 years ago. Such a perfect architecture of the vessels, unique, 300 years before. He was invited for many centers in Europe and showed his work. And this was stimulating. Another thing I like to show you, this impressed me, visiting a neurosurgical meeting in Florence some years ago. We had a chance to visit the Museum La Specula. In this museum, you can see here, this is a model, it looks like a living person. And everything is minutiously, precisely prepared from wax. And this is a Clemente Susudi. And it is an old tradition in Italy. They started also before, but in anatomy, Susini was the master, was helped by great scientists and anatomists, Fontana, and they created incredible number, 2,000 each organs in detail. I was so impressed to see how the brain arteries can be seen here. You see on neck, the carotid arteries, and then in brain is well, and also in the spine. 2,000 preparations are there, and if you have a chance to go, or maybe the Chinese companies will visit this museum and make some picture and give such educative lectures, like this lecture now here. At that time there was no X-ray, no photo, no movies, no videos, nothing. These wax figures have been very important. So it was also made another series in France for Montpellier University, and then Vienna, and one was in the New Orleans in the USA. And this is from wax. It's well kept, not destroyed. Now, this was time period until 1895. It was not possible before, just 60 years before, it started with the photography, first steps. And then Röntgen, German physicist, discovered X-rays. They can go through the tissue and see them inside our body, the structures, the bones, and later on other organs. This was made by him, by a person. You see the entire body skeleton on living person. This is the new area, the visualization area, first steps. 1895. And here is the Professor Harvey Cushing in Johns Hopkins Hospital. He was also a genial person, and he is the founder of, he was general surgeon, but he was more interested in the neurosurgery and was separating neurosurgery. And he used also, 1 year later after the discovery of X-ray, he got a patient, was shot from backside with pistol, and the project was in the cervical spine. He operated this female and helped her on, but on X-ray they could see very well where is the projectile. And this was also introduction of the X-ray in the neurosurgery. And we see here many gentlemen, just few. The Guggenheim, the Oppenheim is in Berlin, is a neurologist. He supported very much Professor Krause. And Professor Schuller is in Vienna. He's a radiologist. He wrote an excellent books about the bones in our head, on the differences, etc. Fantastic book. He was a pioneer. And the next man is the Dr. Professor Walter Dundee, co-worker with Professor Harvey Cushing in Johns Hopkins. He came to the idea to give in the ventricular system in the brain air, because he saw by ruptured intestines the air was in the abdomen. He got the idea. So we had a ventriculography since 1918. And then we have the Leesholm, he developed better X-ray apparatus, and then we have the Sicard, French radiologist. He made the spine and myelography techniques. And here, two Portuguese experts. We have here Professor Muniz, neurologist. He got Nobel Prize for these discoveries, and but not for what he made it. He made it first in dogs' angiographies, and later on human. But he was not the surgeon. Here is Dalima, Portuguese neurosurgeon. He was the man who made the angiograms. And they introduced the cerebral angiography. I forget one picture. Sorry, I didn't like to show the first pictures, but we are missing. The first picture of brain tumors and brain vascular malformation came 1934 around, and published by Moniz and Dalima and Dot in Edinburgh in Scotland. I came to neurosurgery on January 1953. And Dr. Crimeville is a very excellently trained neurosurgeon in England, in Oxford, in London. Then he came 1936 to Zurich and founded neurosurgery in Switzerland. He was very disciplined person in his thinking and working in how he was a meticulous and carefully surgeon. I spent with him 40 years. He was interested what I made it in my training, and I told him I learned a little neuroanatomy dissection. He said, good, then you should now try to do something different. Can you puncture the carotid artery and vertebral artery through the skin? I said, I will try. And next day we started, and I was, you see here on picture, I didn't ask for this picture. On the background is a nurse. The sister of this nurse did like to have the picture from her. Now she was behind the apparatus. We had a installation behind this X-ray apparatus, and what is this? What is that? What is it? What is the arrow? Oh, here. Here, behind. So there was a 6 X-ray films. She had to pull out the cassette. I punctured the artery with a needle and then injected. By injection, immediately I said, go, 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 go. In 5 to 6 seconds, she pulled out 6 films. So this is the time in adults where the blood flow runs. And in children, maybe 4 seconds. We made a serial angiography, and also we had here very unusual apparatus. We made a first series, and for the second series, we changed the axis of the X-ray camera 5 degrees, and whether horizontal or vertical. And then we got a stereo picture. In the picture, we could put left side and right side. In the middle is a mirror, and you can adjust the mirror axis, and then you related your own eye positions. And you could see the vessels like you are sitting in the brain. We saw the arteries at the beginning, then full, and then the capillaries, then we saw the veins, and then full draining system. 3-dimensional, from right or from left, from front, from the back side. So it was a perfect orientation. And our experiences, I made almost 12-year angiographies. At that time, there was no computer tomography, no MRI. So first was an electroencephalography made, and related to the symptom on AAG was made a one-sided angiography or both sides or 4-vessel angiography. Altogether, some 9,000 angiograms were made and put it in these 2 publications. This blue one is the vertebral basilar system, and then the green one is the carotid system. My interest was mainly to study the variation, individual variation of the arteries and the veins. You see here, we could sit here in front and move the mirror system forwards or backwards, or also a little move around. It was a perfect situation. I did like to present in this book also 3-dimensional pictures, but the company said this would be very expensive. So unfortunately, we couldn't make it. Now, being interested of this cerebral angiography, I studied also the special anatomy of the arteries and discovered there are some 10, 12 different segments which are in architecture a little different, and also there are vessels, veins around the arteries, but intracranial they are not close to the arteries. So involved on this special anatomy, we found the brain arteries are different. They have a different outer layer, adventitia, less collagen fibers, lamina externa doesn't exist, media muscle is also gradually getting smaller. Then nerve innervation is reduced. And vascular activity also, vasomotor activity reduced. Endothel regional change. And then very important is vasa vasorum. Vasa is vasa vasorum. Like the coronary arteries, vasa vasorum help for the metabolism on the arteries, on body. But in the brain, they can help only outer layer, outer 1/3. And from inside, it's coming from the lumen, from inside. In the brain has no vasa vasorum. And a lymph vessel was called missing, but the new discoveries show they have a very fine lymph vessel around the brain vessels. In studying the brain arteries, it was clear the brain arteries are not end arteries, not end branches like in a tree. At the end, they come together. They get smaller, but they get connected from one hemisphere. They have a very special connection system. And we have 4 main arteries bringing per minute 500 to 600 cubic blood to the brain, 4 vessels, carotid and vertebral. And then there are also connections to the spinal arteries. So we may have a occluded vessel in one artery or 2, still the patient may have no symptom, or 3 arteries, no symptom. When 4 arteries can get occluded, and still the patient has no problems because the collaterals from spinal arteries goes to the brain. And Professor Kikuchi, who was trained with us in Zurich, he discovered, visualized in 2 patients in Kyoto, such a situation, 4 vessels occluded, spinal collaterals. But it is not so simple. We may have survived with occlusion of 1 or 2 or 3 vessels, but sometimes one artery narrowing, stenosis, or one branch of an artery make problems because the collateral system doesn't work. In children, it is said they work better, partially. So for the young colleague, please think on this. We still don't understand the function of these brain arteries. They have collaterals, but the function is not secured. For some reasons, it's partially well studied, but still not well proved what's going on. So this is very important for us in which cases of an occluded vessel we need to help. Here is another picture of a brain arteries on here red. We may have a occlusion in one artery, okay, but there is a one connection here, you see, main connection. So it can be helped from the other side. But there are small arteries here. They are some way end arteries. If one of these arteries closes, then it's big trouble because they vascularize, support deep center of the brain. And then it can be very negative for the patient. Now, we started to study this system and found also for the young colleagues they should realize we may have a vessel not only 2, 3. And in the middle, the third anterior cerebral artery can be dominant in vascularizing both hemispheres. So any problem to this main artery can be very sequential. Big problem may arise. Now, as I said, the phylogeny I couldn't find in properly publication about the phylogenic development. But in ontogeny, there is an excellent publication. We see in the person within 9 months how the vessel system change and find final condition like here, as you know. And then here, the development of the arterial system and venous system. There is in each book, these pictures are presented. And it is originally made by an artist. I like to show her. This lady, her father was a teacher, and she had a talent, as a child, talent to drawing, and the father sent her to New York to be an artist. But she discovered differences. And so I like to tell, she made 1948 an excellent monography about the embryology. In this book, this picture, what you saw from arteries and veins, she made herself. Great artist. But unfortunately, she died very early on a cancer. Now, she started in New York with an art school, but changed immediately to Johns Hopkins Hospital, to this center. This is the artist center. And one German artist from Leipzig was taken from the anatomy and gynecology professors to Johns Hopkins, Max Brödel. He made this center, as you can see here on the right side. The artist, he trained almost 400 young people as artists. Left side, with the neurosurgeon were trained in this laboratory. And Max Brödel also trained Cushing. Cushing was talented to drawing. So the old publications from Cushing and from Dundee are excellent, or from other discipline. They made an excellent contribution, Max Brodel and then this lady which I showed you. Here is the Max Brodel in elder age, and he said the learning experience would be incomplete without self-investigation. The artist must know that his subject so truly that he can shut his eyes and coax into existence a mental picture, a great clarity, complete in every respect. This means, as you saw on the right down, the pictures are not just photos. They're animated picture. You see, the photo on film and all the MRI and all fixed. The artist, we need the artist because the artist adds from his memory and his imagination, his experiences, informations. So we have an animated picture, and these are very essential. And this was the Max Brodel school. I was planning to come back to Turkey 1960 around, and then my teacher and chairman, Professor Cranby, said, no, we have to publish first, and you have to work on this book. And then 1962, we get a cardiovascular surgeon, Professor Ake Senning from Stockholm. He was an engineer also, and he started in Zurich open heart surgery. On children, he repaired the valves, heart valves, and very few cases happen. And in this case here, what you see, the arrow is so small, and I have trouble to show immediately. But Mr. Ali had showed you. A 17-year-old young lady, by awakening after heart surgery, she didn't move the right side, and she couldn't speak. And then I made the angiography, and saw here one artery, so-called central sulcus artery, and is very responsible for the pre- and post-central gyri, important for the movement and for the sensory. And I showed Professor Senning and said, there is here an occlusion. He got very upset and said, oh, you should go and operate this immediately. But my answer was, yes, sir, but I have no experience to do this. And then I can not imagine we don't have that much small needles and suture material. We have to learn. Thank his insistence, I had to go to learn somewhere microvascular surgery. And it took a while until we found a proper center because they didn't exist. Finally, we found in Burlington, Vermont. Now, on the microscope, I'd like to show just important information. Another Dutch businessman, successful businessman, he had an interest on science, on nature, on biology, and he developed himself a special microscope. Imagine in the 17th century, he made that, he melted the glass, and the drop of glass, they have been like the lenses. So he created lenses magnifying 100 times, 200 times, 400 times. So he could see the red cells. He saw first time brain cells. He saw the spermine. So he was a great discoverer man. But interesting another point. This Italian technician, Giuseppe Campani, in the 17th century, he created this microscope, but it could be used also as a telescope. And then you could see here he is trying to help to see the wound on an injured leg. And the nurse give the light by candlelight. And this was, imagine, it took another 300 years before really an operating microscope was created. It is the society must get ripe and demanding, and for few cases the industry cannot produce, and so the discovery remain unrealized. Here, I came in 1965 in October to Burlington, Vermont. On the background you see Professor Dundee. He was interested to do vascular surgery and working on rabbits' femoral arteries. And here is the head nurse, scrub nurse, Jackie, her surname. Professor Dundee had time one mornings, 3 hours to show me how we can work. But my teacher was this lady, Mrs. Rogers. She was patientful and very strong teacher, and she observed all what I am doing there. And we started first by a rubber tube. Later we started with the rats, and then rabbits, and then later on dogs. And I worked 2 months on extremities. Then I did like to work on brain art of the, sorry. Another remark, the brain, not brain arteries, the vessel surgery was started in the 18th century, 19th century laboratories. And here is Professor Alex Carrel from Lyon in France. He went first to Canada, Montreal, then went short time later to St. Louis and worked with Professor Guthrie. He was in Chicago physiology professor. He had a good laboratory. So he learned by him the first steps of the vascular surgery. And he's a genial person, and he had ideas to do also more and more and more. And he made an organ transplantation on animals successfully. So it started actually by Professor Carrel and Guthrie. Professor Carrel became the Nobel Prize, and his principle was to have this 3-point fixation and then repair with some 10, 12 suture. I never used this because I put inside a soft tube, and then last moment I removed. I will show you later. Here are the patients, Dr. Dundee. With Dr. Dundee was working Dr. Julius Jacobson. He was cardiovascular surgeon from New York, appointed to Burlington, and for a pharma company, he should study what happened if the carotid arteries ligated, etc., and then sutured again. His assistant from Argentine, Dr. Suarez, saw in corridor in laboratory size microscope. Said, "Sir, can we use the microscope?" He said, "Okay, we do this." And then I will show you what he made it. So it started repair of the vessels under microscope. They came down to 2 millimeters. In here is Dr. Harry Banke. I visited 1966 some 10, 12 centers in the United States, mostly plastic surgeon, cosmetic surgeon, vascular surgeon, and they have been interested to make a precise anastomosis. And Dr. Banke showed me one monkey and said, "You see, on this animal, I made a transplantation between thumb and big toe, and it works, and this is important." I was very impressed from his work, was very precise. But we lost him, unfortunately, on a car accident, by motorcycle accident. Now this is the preparate, what you see here on the upstairs, on upper corner. End-to-end anastomosis made without microscope. Here with the microscope. This was given to me by Dr. Jacobson in April 1966. I like it. I started to do brain artery surgery. I insisted, saying, "Dr. Dundee, sir, I have to do some help for the cardiovascular surgeon in Zurich." So we started to operate first on the basilar artery. Approach was transcervical, transclival, and a small opening. And I made even on this case a patch. I took this artery some 1.5 millimeter. And at that time we didn't have a fine needle and then suture material. And you see here it worked well, and then I like to show this dog. This was a dog. He survived very well. It's interesting, as I met him first day, he was barking. But later he got a good friend. I walk with him every day around the laboratory. Now, here is the first case. You see the brain artery in 1 millimeter. It is smaller than 1 millimeter. The point is, the artery is not on the surface, but covered by arachnoid and arachnoidal fiber system, like a spider network around the arteries are very fine fiber systems. So just 1 centimeter opening of this segment needs real time on patient. You see, I made it well. You see the gyral area seems normal out, and I made a patch. This worked, and then I said, Dr. Dundee, sir, the new area neurosurgery should start. And you see here end-to-end anastomose, and here is a graft, double, just exercise. And here extra intracranial bypass on a dog. This was possible thanks to bipolar coagulation technique of Dr. Mallis. Leonard Mallis was in Mount Sinai Hospital and very close friend of Yung Peng Huang, and he developed this operate bipolar coagulator so we could make just a small point bipolar coagulation. I used at the beginning forceps for watchmakers. They are 6 different sizes, 0 to 5. By 5 is the end is like a needle. So you can make just 1/10 of a millimeter, small coagulation. So we could keep the area very clean. Unfortunately also we've lost Len Mallis early. And this was a great help. Microscope and bipolar coagulation. And we developed, later you see the series, almost 30 different lengths and tip size. You can make it much more, maybe better. Okay, because we are working on brain, on surface, but we go through the cisterns down, sometimes 10, 12 centimeters in depth. So we need special length. Now, 1953, there was a revolution in the optic system. Dr. Littman succeeded to produce this OPMI-1 microscope with electricity, and you could move, and this was good. But we found we need in neurosurgery much higher mobility, and we developed counterbalance system and with electronic control, with a brake system to stabilize and to move. And you see me here sitting on a hydraulic chair and also armrest. It is very important to have forearm and hands stabilized, because 10 minutes you can stay in the air, but 2-3 hours you will start to have a tremor. So this hydraulic armrest is also mobile. Can you move 360 degrees around? Is very essential. And the microscope is now advantage between ocular and objective short, and it was a problem of a heating, because the ocular get after a while foggy, so we started put cable and make a heating, light heating. And then here the mouthpiece, if I push here, it released the brake, and I could move with my mouth, whole microscope, because if there's a 30, 40 kilogram counterbalance, it is easy like a feather. if it's a good balance. And now, we discovered later that the astronomer for the telescope use also a heating system like this. I put here the name of the company. And we needed also temporary clips to stop the blood flow in the arteries. Just a few minutes. And originally we made it just 4 or 5 clips, but later they created 180 such a clips in length and fine, and we made also one very small for small vessels. Now, another essential part is what the microsurgery is to have these cotton patties. They can be very small or large. They keep the area clean, and I will tell you why. Later I will show you. Here, 1967, in January, I came back to Zurich, and then we waited for a while until a case came with a good indication for surgery. A young man, 27-year-old, not smoker, and healthy, but he got an acute stroke, but temporary. He was full recovered as he came. And I said, look, you have the inferior branch of the middle cerebral artery is occluded. You may have more trouble. He accepted, and we see here yellow sclerotic part of the artery of the inferior trunk. And then I opened it and then made some 20 single suture. It was well opened, you can see angiographically. How come this sclerosis occurred in a 27-year-old person? He's not a smoker. We all react as tobacco make, but there are other genetical factors we don't know what. This was the beginning. Now, this surgery was made also by other surgeons, neurosurgeons. I put the name here. And without microscope. But the point is, these arteries are in the fissure and in the sulci. And they are covered by arachnoidal fibers and the membrane. We can open the membrane easy, but the arachnoids are so small, like the small vessels. It's better to do it under microscope. None. The point is here. These operations on patients with occlusive intracranial vascular disease have been approached with great apprehension and hesitation because the indication for operation in such cases has not been delineated. Now we are in September 2020. Still, we don't have any clear method to show us whether this person has now the symptoms and improved, whether he will get again, when, and whether light again in a small stroke or big stroke. It is unclear. We have no method to control the function of the collateral system. In individual case, there is no precise method to determine whether spontaneous recovery or repeated attacks with progression of the disease will occur. So I operated altogether only 7 patients with middle cerebral artery. And then Professor Fisher in Boston is a neurologist. He was very interested on problem of the blood circulation of brain and stroke problem. He said, it is even conceivable that someday vascular surgery will find a will bypass the occluded portion of the artery during the period of ominous fleeting symptom. Anastomosis of the external carotid artery of node of its branches with the internal carotid artery above the area of the narrowing should be possible. Nun, sorry, I couldn't read well, but he declared clearly, once a day it should be made a bypass. And this was made. Worringer, neurosurgeon in Colmar, French, and Kunlin, vascular surgeon in Paris, came together and made a first anastomosis 1962 around, anastomosis between external carotid and intracranial carotid, a complicated way. It was very successful, performed, but the patient get a pneumonia and died. So this was unfortunate. Now, in 1967, October, one patient came with symptoms. He was at that time 57-year-old gentleman, engineer. He said if he turned his head to the left side, he get a weakness on the right side and fell down. And I made him, myself, the angiography. As you can see, the right internal carotid occluded, left also occluded, and the right vertebral I couldn't puncture, but the left side, you see, from the left vertebral, entire brain is filled. There are also other collateral for the brain circulation, and transorbital or from backside, from occipital artery, but this is the main way. So this was the situation of this gentleman, 3 arteries occluded, only the left one open. And then we see also sometimes only a segment of carotid artery can be occluded and hinders the collateral system working. Sorry. I said to this gentleman, I know now technique I could help you making an extra intracranial bypass. He was enthusiastic. He said, oh, okay, we do. And we made it. You see here is on the surface of the right temporal area an artery. And you see, here is the artery, and then here is the superficial temporal artery. And then we made anastomosis. It was working. And you see the collateral. This was the first case on a human case. It works, bypass. You see the gentleman here. He's standing also on his left leg. Now, short after, it came critical remarks. They made studies the negative results of this study no longer allow us to believe that bypass surgery is an instrument of consequence in the prevention of the stroke. I didn't react immediately because the point was correct. Some colleagues, they visited us in Zurich only one day or 1 week or 1 month or 1 year, but some of them, they started to do this bypass routinely, just for business reason. And they made many, and the insurance companies get nervous about this situation, and they asked for this result. And now the point is, I will come back to this point. Forget now the occluded arteries, but we have situation like in this lady's case. She was at that time 18-year-old, had no bleeding from this giant aneurysm of the internal carotid bifurcation, but she began to develop left side weakness. I offered her, we can see whether we can put a clip, but it was a very large base, and I put ligated the internal carotid artery distal to the anterior carotid artery and made an extra intracranial bypass. She's still alive. This was 1968, and she's doing well. She's married, had children. So this is one possibility, and it can be used by aneurysm and by tumors. And then this disease, this is discovered by a Japanese colleague in 1957 called Moyamoya Disease. And interesting here, the vertebral artery filling not only the cerebellar and cerebral, also in the encephalic area, enormous micro arterial system, increased one. And in this case, Professor Ture had both sides, anastomosis made it. And you can see it is both sides made and very well. And this congestion of the microarterial disappeared. This phenomenon I don't understand. What type of a micro collaterals are there? This is not well clear. Now, this can happen to the children. This can happen also to the adult person. And it's happened 1972. We get a family coming from Belgium with a 6-year-old boy. He had some mental problems, and then some seizure type, and we found he has Moyamoya disease, bilateral carotid. In my knowledge, bilateral vertebral, I never saw it. So I made this 1972, and Dr. Kreinbill published this 95. This is for the colleagues' information. This was the first case of Moyamoya bypass, extra intracranial, because it is very difficult. The vessels are so much smaller and need more patience. Now, coming back, the point is here academic. We are mixing two clinical conditions. One is the full stroke, ischemic stroke. The population notice either only arm or arm and leg, and also speech trouble or completely lost. Or they can be only short symptoms, problem with the eye, or some weakness a little, short time. We call this temporary ischemic attack. In these cases, if the angiography show some occluded segments, 1, 2, or 3, we need bypass. But if there is a full stroke and hemiplegia, aphasia, and the CT and MRI show us infarct without hemorrhage. First infarct, later they may have a bleeding. So the stroke is another disease. The circulation problem is different. And this was interesting to tell you here. 1628, William Harvey, English scientist, he visited and learned in Italy. He got information about the vessel system, and he first time presented the blood circulation of body. And this was also published in a book, monography, 1964. There were pictures from great English architect Wren. So this is now well known as circle of Willis. So connection between the both in anterior cerebral and the posterior cerebral to the carotid system. And then Malpighi also discovered the capillary system, so it was complete knowledge. But it is some way forgotten one Swiss physician, Wepfer, in Basel studied, he wrote 1685, a voluminous book I had in my hand from the library in Basel. And he described in this book precisely the circle of Willis, but there is no single picture. So we should mention him also correctly. Here is a Willis and the picture of Wren, and then later on drawing how we. Now the discussion. You see, this picture is made in Kenya, Nairobi. There was a surgeon who was trained by Dr. Senning in Zurich, heart surgeon. Then he returned home and he discovered this case. You can see an internal carotid artery is stenotic before bifurcation and poor branches. But the nature created from extracranial occipital artery a connection to the cortical artery. So the nature made actually the first extra intracranial bypass. I never saw such a case, but Professor Ture told me he saw some cases. I don't remember. Now another question arises: if the brain needs blood, we need also a better extra intracranial bypass. You can take a saphenous vein, or you can take an artery and make a free transplantation and connect to the carotid artery. This is not my opinion. I tried to do this on dogs, it didn't work. And I said superficial temporal artery is 1.5 to 2 millimeter size, but if the brain needs blood, it will get larger, and this is the case. This extracranial arterial system is a good supplier for the brain circulation. I published in 1968 this microvascular surgery. This is now the new edition. If the colleague would like to see a little more detailed information about the bypass technique, we will find there. Then later on, I published this second book after I had some 3-4 year experiences in surgery. Here are the T-tubes. And then this is a company, unfortunately, it's closed. They cannot. There are very small, less than 1 millimeter tubes, or for the carotid artery, larger tubes. We can cut the ends a little shorter, and you don't have to put that much in entire length. So, because the blood circulation should not be interrupted. Even if it's only a few minutes, 5 to 10 minutes, if you put such a tube, you can work in half an hour or 1 hour quietly, properly. Now, one more. I like to I operated only few cases carotid arteries because they have been operated in the general surgery. And so they went well, what I made it. But here I like to show this publication in European Journal of Vascular and Endovascular Surgery. You can copy here. It's an excellent summary what was made in laboratories and later in human, if you like to read it. And then there is another publication here from Journal of Vascular Surgery, 2014, from Friedman, about the topic who made the first carotid end arterectomy. And interesting, they made the first ligature and then end-to-end anastomosis to the from the external or from direct internal to internal. And Debicki made a just incision and remove the sclerotic part and make the suture. So there is a discussion now who was the first. First was the made it in Carrea in Argentine. Yeah, you can read this in this publication. I hope I gave a little information for the young colleagues where we are still in big problem. Still, we don't have a very proper method to measure the brain capacities, especially hemodynamic capacities whether it will recover itself or is a big danger is there. And this is the main problem. Surgical technique is there. We can go down even to 0.5 millimeter size. But the problem is a good indication. I heard from Professor Ernest Niemi, one Chinese neurosurgeon made already 7,000 extra intracanal bypass. I like to read the result, how it looks, and what indication was given, etc. Would be very interesting. Hi, you are. Good luck for your work. Bye-bye.